It's evening here, and we just lost power, so that's why it's dark, and that's why we're starting a few minutes late, I believe. But anyway, we're making it work, and we're pleased to bring you Dignitas International's first live interactive webinar. I'm Sumeet Sodhi. I'm a research scientist with Dignitas International, and it's my pleasure to be your moderator this evening. Joining me are my colleagues, my panelists, Ken Phiri, our research manager, and Dr. Joep Oosterhout, our medical and research director. Because this is our first webinar, and sort of given the Malawi context that we're in and the lack of power, we apologize in advance if we have any technical difficulties. If we get disconnected, we'll try to connect back on as quickly as possible. We are recording this webinar, so if for some reason we can't get back on, we will post the recording as soon as we can. So for the next hour, we'd like to give you a first-hand account of Dignitas's efforts around prevention to mother-child transmission of HIV. We call it Pmtct. For the first half hour, we'll start with a primer on what Pmtct is, and give an update on our research activities in this area. And then for the second half hour, we're going to turn it to you, the webinar audience, for you to pose questions, and we'll do our best to answer them and hopefully have some good discussion as well. All right, if you have questions for any of us about Pmtct research while we're doing the first 30 minutes, please email them to webinar@dignitasinternational.org. That's webinar, W-E-B-I-N-A-R, @dignitasinternational.org. All right, so let's get started. So, Ken, my first question is for you. Can you give us a snapshot of the HIV epidemic in Malawi and how it relates to infants being born with HIV?
Well, in Malawi, over the past 2 decades, Malawi has been struggling with the HIV epidemic.
Mm-hmm.
The rates of the rate of infection is actually 11%.
Mm-hmm.
But in some areas like Zomba, where Dignitas International operates, it is as high as 18%.
So that's like almost 1 in 5 people if you're getting at 18% prevalence, isn't it?
Yes, it is that high in some areas.
Yeah, and what about pregnant women? What's the prevalence rate in women?
In pregnant women, the figures are the same, 11 to 18%, so which is also quite high. And then if you look at the number of births that are given in Malawi,
mm-hmm.
which is around 500,000 a year, with those percentages, it is quite possible that HIV transmission from mother to child will indeed be very high.
Right.
In fact, it is estimated that around 20,000 babies are born with HIV as a result of mother-to-child transmission in Malawi only.
Only in Malawi. What about on a global scale?
On a global scale, the figures are around 330,000 children born with HIV, transmitted from mother to the child.
And that's primarily in sub-Saharan Africa, as we'll learn in terms of the interventions that we're using and that sort of thing. Can you explain to our audience exactly how HIV is transmitted from mother to child now that we have power back? I think they'll be able to see us a little bit better as well.
Yes, that's a lot better. Yes, so HIV can be transmitted from mother to child through 3 different stages.
Mm-hmm.
It can be during the pregnancy, it can be during labor and delivery,
mm-hmm.
and it can also be in the breastfeeding phase. In pregnancy, infection occurs because HIV-infected cells from the mother go through the placenta into the circulation of the infant. This also still happens during labor and a little bit during delivery as well.
Mm-hmm.
During delivery, when the infant passes through the birth canal, blood from the mother can go through the eyes and the mouth, the mucosal surfaces of the infant.
Mm-hmm.
And during breastfeeding, HIV that is in the breast milk can infect the infant through the gut.
Right, of course. And what are the rates of HIV transmission at the different phases?
Overall, if you include breastfeeding, the average risk of transmission is between 25 and 40%.
Right.
The lowest risk is in fact during pregnancy.
Mm-hmm.
We think about 6% or so.
Mm-hmm.
And then the highest risk is during the phase of labor and delivery, at least 15% or so. And then during breastfeeding, it depends on the duration of breastfeeding and some other factors, but it's estimated that it's around 4% per 6 months of breastfeeding.
Right. So if you add up, you said the overall rate is between 25 and 40%. So I imagine that there's some risk factors that get you towards closer to the 40%. So can you explain those a little bit for us?
Yes, that's right. So it's not the same for each person or for each woman. And through various studies, some risk factors have been identified. One risk factor is vaginal delivery as compared to cesarean section. Another risk factor is preterm delivery, so early delivery. And another risk factor is when the membranes have been ruptured for a long period. But really, the most important risk factor is a high viral load, a high HIV viral load in the mother.
Right.
And that is actually what we try to influence to prevent transmission of mother to child.
Right. And so what do we do? So yeah, that would have been my next question. How do you prevent the transmission from mother to child? And what are the different ways that we can do that?
Yeah. So what we do, the most important measure is to give antiretroviral drugs, anti-HIV drugs, to lower the viral load in the mother.
Right.
There's a few other measures, but this is the most important one.
Right.
Over time in Malawi, we initially started with providing a single drug at the time of delivery to both the mother and the infant.
That was the single dose nevirapine.
Yeah, that was called single dose nevirapine.
Right.
It was a simple and straightforward measure,
right.
But it was only partially effective, about 50% effective, and it didn't address the transmission that occurs during the breastfeeding phase.
Right.
Then we went on to providing ARV drugs and combinations of ARV drugs, right. Starting during pregnancy after the first trimester, and this was more effective, but it was also considerably more complicated and therefore logistically more demanding. And then, so we're going now to the more recent times and what we do now, and we give full combination antiretroviral therapy to pregnant women after the first trimester.
Right.
Continue this through pregnancy and delivery,
right.
And then continue this through the breastfeeding phase.
Right, right. And what's the transmission rate that we're aiming for with this? We call it option B. Is this what you're talking about, right?
Yes, that's right.
So what's the transmission rate? Expected transmission rate. So we're going to talk about the challenges in a second as well.
So if this is implemented optimally, women starting early during pregnancy, adhering to the treatment well, the rate of transmission can be reduced to as low as, let's say, 5% or less.
Or less, yeah. So that's highly significant, isn't it?
That's a huge improvement.
Huge improvement for sure. And so that's option B.
Yeah.
Now,
so maybe just one point to add.
For sure.
If an infant gets infected,
right.
The risk of such an infant surviving for 2 years, if left untreated, is about 50%.
Right, so that's if there's a HIV positive infant that's born, you're saying the mortality rate is up as close to 50% in the first 2 years.
That's right.
Yeah, so basically the point I'm hearing then is this is a significant issue for these 20,000 infants that are born in Malawi, as well as those over 300,000 infants born across the world as well. Right. So we talked about option B. Ken, can you tell us about option B plus? Because when we talk about Pmtct in Malawi, our supporters and our friends on the interweb have probably heard of option B plus. Or if they haven't, can you tell us what it is and what we're doing in Malawi that's so special?
In option B plus, what we're doing is that every pregnant woman or every breastfeeding woman is tested, and then if they are found to be HIV positive, they are started on ART or HIV medication, the antiretrovirals. That is regardless of whether they are showing signs of being ill or unwell or not.
Right.
So if you are breastfeeding, you are pregnant, you are HIV positive, you are on treatment. So that is the option B. Now, the plus factor side of it is that after delivery and after breastfeeding for about 6 months, the women are not weaned from the drug. They are still provided with the drug. So that is the plus aspect of the option B.
Right. So it's lifelong.
It's lifelong treatment, yes.
Right.
So Malawi is actually the first resource poor or resource challenged country to implement option B plus.
Right. And when did we start doing this?
Should be in 2011.
Right. Right.
Yeah, that's right.
Yeah. And we've reached quite a few women even in this short year, haven't we? I don't remember the number.
It could be as high as 100,000,
yeah,
I believe.
So we've made a good start anyway in the southeast zone, the area where Dignitas works with the Ministry of Health on this, right? What are the benefits of option B plus? So we've talked about the benefits to sort of the mother and the child in terms of health and HIV-free survival in the infant, but there's some health systems benefits, I imagine, as well, right?
So the benefits are indeed there. In the first place, it's not complicated in such a way that it requires a lot of technology.
Right.
It is easy or simple to implement. And the second thing is that it doesn't require any CD4 count. As I said, the criteria, if you fit that criteria, you are started on treatment. And the other benefit is that in Malawi, ART treatment is decentralized. So even if you are in the remotest of the remote area, option B plus will benefit you. But if you are in the urban area or in the villages, you will still be able to have access to the medication. So there is equitable access of medication. And it also provides protection for the for the kids, for the children that will be born later.
Right.
Remember, we've said the mother will be on treatment. Even after delivery, she will still be on treatment if she was HIV positive. And so that if she becomes pregnant again, she's already on treatment. Right. So there are a lot of positives, a lot of benefits associated with option B plus.
Right.
You perhaps might want to add.
Well, I just wanted to say that is important in Malawi, because Malawi has such a high rate of pregnancies per woman.
Right, it's like 5 or something.
Yeah,
right?
probably 5.5 or so pregnancies per woman. So that is then important. If ART was not continued after breastfeeding, it would mean frequent starting and stopping of ART, and we know from previous research that has disadvantages.
Yeah, disadvantages to the health, probably disadvantages also in terms of resistance and treatment failure and all of those other concerns that people raise around option B, like option B in and of itself, right?
That's right.
And I guess one of the benefits that I've always sometimes we don't always talk about. We talk about the children and HIV-free generations and the benefit to the infants. There's a benefit to the mother of just being on ART. She's healthier, more productive, and can live her life you know, to what she wants to do as well,
Yeah.
right?
Yeah. There are studies that have demonstrated that even women who have a relatively high CD4 count, so a fairly strong immune system, still have considerable diseases and even an increased risk of death in this period of pregnancy and after delivery.
Right, and then women also, once they stop breastfeeding, they often get pregnant quite quickly again as well. So,
Yeah.
so then you're looking at someone who could be ill for quite a prolonged period of time during her reproductive years as well without this. You mentioned research, so I think this is a good segue for us to talk about the different types of research studies that Dignitas is involved in. Maybe you can start and tell us what's on the horizon and what we're doing now.
Yes, before I introduce the two studies that we are involved in, it's maybe good to start by saying that although the Malawi Ministry of Health had strong arguments to introduce option B+, they didn't do so on the basis of strong available evidence.
Especially for that plus part, right?
Yeah, exactly. In particular because that evidence was just not available.
It's not there, yeah.
So now it's extra important after the introduction to try and collect that evidence as we are implementing this strategy.
Yeah, for sure.
So the first study I wanted to talk about is a study that we do in different parts of Malawi with various partners. And it's a study that looks at different interventions to improve uptake and retention in care for option B+. We are comparing two new interventions with the standard of care in a randomized controlled trial.
Right, so so there's 3 arms in the trial, two separate interventions, and then standard of care. So maybe we start with the interventions. What are they?
Yeah. So both these interventions make use of what we call expert patients, in this case expert mothers.
Right.
And they are women who are openly HIV positive. They're willing to disclose their HIV status to the general public. And they've already made use of the service of prevention of mother-to-child transmission. So they're on the ART. And after a relatively short training, they are used in 2 different ways. One is at health facility level. That's the first intervention or model of care, if you want.
Right.
Where they act as a mentor to women who visit that health facility. And in the other model of care, which is at the community level, so close to where women reside, where they live, where we form community support groups that also contain one of such expert mothers.
So one is at the health center, the first arm is at the center, let's say, and using these expert mothers. The second arm is close to home, near the villages or closer to home in the community, using this expert patient or expert mother model.
Yeah, in a community support group.
In a group. And then what's standard of care? Because the third part, you mentioned standard of care.
So standard of care is just the routine care as it is right now.
Right.
And that lacks any of such support mechanisms.
Right. So that it lacks the peer support or that mother support. It's not that the women don't get support, they get the counseling from their healthcare worker and that sort of thing. But that's it. That's where you leave the health center or you leave the consultation room, I guess. And standard of care doesn't involve any of the other supports.
Yeah.
So.
And the question of this study is whether if you introduce either that health facility-based model or that community support model, whether you can improve uptake and retention of option B+.
So those are the outcomes that we're looking at, uptake and retention. And how long is the study, and how many women are enrolled or going to be enrolled in the study?
Well, we haven't started the trial yet, but we've done the preparation phase that was done with qualitative and social science research to develop these 2 different models of care. We've done that now, and we expect that the trial will start in 1 or 2 months' time.
Right. And how long does this trial run? How long will it end up running for?
It will run for 3.5 years.
Okay. And then, so we may be sitting here on a webinar at some point in the future talking about the results.
Let's hope so.
Yeah. So you mentioned there you wanted to talk about 2 studies. So we've talked about this, the PURE study, the models of care.
Yeah.
And then what was the other
So
one?
the second study is a large nationwide study that wants to evaluate the program of Option B Plus as it currently runs.
Right.
Looking at the actual rates of prevention of mother-to-child transmission,
Okay.
the effect of the measure on mother-to-child transmission,
Right.
and also at the health outcomes of mothers as well as their infants
Right.
over a longer period of time.
Okay.
So a large group of women from a nationally representative sample will be followed for about 4 years.
4 years, 48 months. Right.
48 months.
Yeah. So, and this is to evaluate Option B Plus in the real world setting as it's being rolled out and used by healthcare workers, starting patients on antiretroviral treatment in the health
In
centers.
the daily reality.
In the daily reality, that's the words I was looking for.
And we're doing this study together with the Ministry of Health
Right.
and with the United States Centers of Disease Control,
Right.
and with a partner NGO organization in Malawi.
And you said that the study is going to go for 48 months, for 4 years, but we will probably have some interim results to report
That's
soon
right.
before that. I
So
hope.
we expect to be able to provide some results after 12 and 24 months already.
And how many women are we enrolling? How big are we talking about?
This is a study that will enroll 3,500 women and infant pairs.
Right.
And if funding allows, this may be repeated once or twice.
Wow.
So it's really a huge study.
Wow. Yeah. So we look forward to that.
And we hope that it will provide policymakers with decisive information.
Not just in Malawi, right? Because
That's true.
other countries are looking at Malawi's results and asking for this evidence to see what the effectiveness is. So what is happening in the real world when you do it.
Yeah.
Great. And where are we at in terms of this study? We're just starting, right?
That's right. We are preparing the study now, and we are submitting the protocols to the ethics committee, and hopefully, in positive, optimistic scenario,
Right.
we expect it to start in a few months' time.
Okay, great. I think I'm going to stop us there because it's 6:30 now, so we've gone through sort of the first part, and I promised at the beginning that we would address questions and have discussion for the second part. So
Okay.
if there's anything else you guys have to say, I'm sure it's going to come up in the next 30 minutes. So I have my iPhone here. I'm going to actually look and see if we have any questions. Otherwise, there were some that were sent previously as well. So let's see. We've got a lot of questions. So the first question is Jason from Kingston, who is asking, how do we prevent mother-to-child transmission in North America? I can take this one because I'm a physician that works in Canada as well. So in North America or in Canada, we've dealt with prevention of mother-to-child transmission actually almost a decade ago. We start women, we test women for HIV pretty much within the first trimester of pregnancy. If they're HIV positive, they go on full antiretroviral treatment right up until the end of breastfeeding. And as well as antiretrovirals, women are offered cesarean sections, which, as we heard from you, decreases the risk. If you don't have vaginal delivery, decreases the risk of transmission. And then women also in Canada have the option of not breastfeeding and formula feeding. So if you're not breastfeeding your infant, you're not exposing the child to HIV. That actually brings up a follow-up question that maybe I'll ask you. I've just been talking about how we don't breastfeed in North America, but we do advocate for breastfeeding in Malawi. Can you sort of briefly help us understand that?
Yeah, I'll try. If studies have been done to look at this question, and they looked at women who were advised not to breastfeed in African countries, and instead substitute to so-called formula feeding.
Right.
But introduction of formula feeding in Africa is very challenging. It's extremely expensive, and the preparation is difficult. And if you don't use very clean water, and it's sometimes difficult to get to very clean water, then there is a risk that the infant will experience repeated infections with diarrheal disease.
Right.
And these studies then looked at, that they compared groups of children that were breastfeeding and that weren't breastfeeding. And even taking HIV infection and its complications into account, the groups that were breastfeeding still had better outcomes if they did.
Yeah, so that's
and I think you also have to understand that with the introduction of this extended antiretroviral therapy through breastfeeding, that really dramatically reduces the chance of HIV transmission during the breastfeeding period.
right. The viral load in the mom is down, so the viral load in the breast milk also decreases, so the transmission can decrease during that.
So the combination of continued antiretroviral therapy through breastfeeding period plus having breastfeeding gives optimal outcomes in our setting.
Yeah, that makes sense. All right, so let's move on to the next question. Sarah from Toronto is asking, what are some of the concerns related to adopting an option B plus treatment strategy? So what are the concerns and challenges? We've talked a lot about the positive effects and the benefits, and so I think this is a really important question in terms of what are the criticisms, what are the concerns, what are the challenges around this as a policy?
Well, there are a number of challenges or concerns related to adoption of option B plus. Remember I say that HIV treatment or care is now decentralized, but previously it was centralized. So if a patient had, if an HIV patient was discovered, they were referred to a central or a general hospital. But these days they will be treated wherever they are in the villages.
Right.
But we all know that even during the centralized era, there were shortages of medical staff or medical personnel all over, especially in the rural areas. And now we have this decentralized system, and everybody who is, every woman who is HIV positive and is breastfeeding or is pregnant is receiving treatment maybe from the rural community somewhere in the deepest of the rural areas. That increases the workload of the healthcare workers on those in those health facilities. So there is quite a concern in terms of workload for healthcare workers. But I think the other challenge that I can mention is related to the fact that Malawi, as well as most countries in Southern Africa, still have strong beliefs in some traditional medicine. And I'm not saying traditional medicine is bad. A lot of medicine has been developed from traditional medicine. But if you grab a newspaper, if you tune in to your radio, you will find that in such a village or in a certain village, somebody is claiming to have discovered HIV medication. And then if that the word gets around, women who are on ART stop and start going to those people. And then that breaks, their participation in taking this lifelong treatment. So those are the two challenges that I can relate to. There is, of course, another challenge, which is about sustainability. We did say Malawi is a resource-challenged country. Our budget, as well as money or funds that are used for HIV programs, is mostly donor-funded. Are we going to continue, if we're going to continue with providing HIV treatment to every pregnant mother who is HIV positive or breastfeeding mother who is HIV positive, will the funds to sustain such program be available? So those are three challenges that I can think of, but I'm sure you might have one or two.
Yeah, no, I agree fully with you with those. Maybe there's one slightly different concern that I think is also important, and that has to do with the fact that most women who access option B plus Pmtct are quite healthy. Most of them have not experienced any HIV disease.
Right, yeah, they have higher CD4 counts than...
And then the question is, how motivated are these women to continue lifelong treatment that sometimes may have side effects?
Right.
Are they motivated enough to follow the quite strict demands that this therapy asks to be effective? Or will this lead to regular treatment interruptions or missing tablets over time?
Like skip doses or something like that, right?
Exactly.
Yeah.
And I think most people probably know what the consequences of that would be. That's namely the development of drug resistance.
Yeah.
And once an individual has developed drug resistance, her treatment will no longer be effective.
Not only that, if she develops a drug resistance, then isn't it a possibility that she can transmit a resistant virus as well? Right?
Exactly.
So
the worry of this is that will it increase the speed of resistance through the population, rendering the first-line treatment ineffective and on a larger scale. So I think that's quite a concern, and it's really important to target your research in trying to find out how to prevent this.
And are we doing anything about this?
Yes, yes, we are. Yeah. In fact, with both these studies that I've mentioned, we are looking at ways to improve retention and adherence, and we are trying to evaluate how effective and what type of resistance and treatment failure occurs in the long term in women who start option B plus in Malawi.
Right, so we're doing some viral load monitoring and some viral resistance monitoring as well as a part of the studies.
That's what we want to do.
Right, okay. All right, let's see what other questions we have. All right, this is probably one for you, Joep. What are the side effects of treatment for mother and for the fetus?
Yeah, that's a good question, Sumeet. In the ARV regimen that we provide for option B plus, there are 3 drugs, and each has some side effects.
Right.
One drug is called Adherence,
right,
and that drug is associated with complaints of dizziness and sleep disturbances,
right,
and sometimes also with skin rash and damage to the liver. Fortunately, these side effects are not very common. I think one particular concern in the past has been that Adherence can also cause damage to the fetus if taken during pregnancy.
Right, or that was a concern in the past, but you're going to tell us something else? Maybe?
Yeah, it was a concern in the past, and fortunately, with the longer use of these drugs, many pregnancies, many women have used Adherence during pregnancies, either unknowingly, but they weren't aware that they were pregnant and taking it, or were willing to accept the risk. And so we now have data from many thousands of pregnancies, and it turns out that that risk is actually quite small. And if offset against the large benefits of the treatment, we now believe that from a public health perspective, it's a good drug to use.
And an appropriate drug to use in this situation.
An appropriate drug, yes.
Yeah, okay. So, more questions have come in and are coming in. How long will ARVs keep the mother alive and healthy? Well, I mean, I can take this one. It's short answer, I think. So in theory, life expectancy of a woman, a mother who starts antiretrovirals and continues it, her life expectancy approaches the life expectancy of an HIV-negative woman. But that's that's theoretical, and it's a really, reason I said it's a short answer is because it's a really good question. We are just starting to start women on this type of regimen, and the studies that you've mentioned will shed more light on the answers. So to be determined for sure. Okay, we've got a few more questions coming in as well. All right, and I think we still have quite a bit of time, so that's good. All right. Okay, Ken, I'm going to ask you this. This is Tony from Kingston who's asking us, what are the future plans for our PMTCT program?
We will definitely continue with PMTCT program because this problem may still be there for quite some time. But what usually happens is when you are trying to address a certain research question related, say, to PMTCT, other smaller questions do arise, which supports or which gives in more information that helps the main study. So we will continue to work on PMTCT programs and the related or the new questions that will keep cropping up.
Right.
We are going to also be looking at other issues that come out of PMTCT that can be, or that probably are not very clear. Remember, at Dignitas, we don't only do research, we also do medical programs, medical work. So as our clinicians, our nurses, and our medical people are doing the program work related to PMTCT, certainly some questions will be arising.
Right.
And as researchers, the research part of the team will continue to try to find answers to those questions.
Yeah, so we can predetermine some of the studies, but because we do the medical program and have the operation research objective, we have the flexibility to come up with new questions as we go along as well. I think that's really important for sure. All right, so we're getting more questions. All right. So
maybe Sumeet, just to add on that.
Yeah, for sure.
Within Dignitas, we also have quite a strong social science research team.
Right.
And there are important questions arising from this program that need evaluation by social scientists. So
right.
those are also some of the plans that we continue to do social science in this particular field.
Right. So alongside all of the clinical questions and the epidemiological questions, we're also able to ask things like why do things happen the way that they happen, as opposed to is something happening or not, or is uptake happening or not. We can ask the question, what are the barriers to uptake? What are the facilitators to uptake? And orient our program to strengthen the facilitators and overcome the barriers. I think that's really one of the key things for sure. All right. It looks like we have about 15-20 minutes to go and still a list of questions. All right, the next question is David from Peterborough, and the question is, what is the biggest obstacle to overcome in delivering our PMTCT program? All right, so I think we probably all have opinions on this. Does somebody want to start? And please chime in because we have a lot of challenges, that's for sure.
I gave my first shot at the challenges, so I'll let you.
Fair enough. So you're on the spot.
So yeah, you can understand this question in different ways. I'm reading the question is what are the biggest obstacles for women to access care, PMTCT care in Malawi, and I think it's a good question because these barriers are for a large part quite different in Malawi than they are in other parts of the world, in particular in more rich countries. So people need to realize that going to a health facility for a woman in Malawi is not a small thing. Often women have to travel quite a long distance. It's not always safe, and it's often expensive as well. If they have to use transport such as a minibus, it can consume up quite a large part of the budget that they may have for the family. So I think that's one. And the second important challenge, I think, for women are issues related to disclosure and stigma. And disclosure in particular to the spouse. And so the theme of male involvement in this type of care of prevention of mother-to-child transmission is increasingly important. So if women have not disclosed their status to their spouse, if men are not involved in supporting their family, then it becomes a far bigger challenge, and the chances of success are reduced, it seems.
Right, for sure. So we do have a male partner involvement initiatives as a part of the Pmtct program with the work that we're doing in the Southeast Zone as well, right?
Yeah.
So, yeah. Any other challenges that you think are important, either of you? I think one of the other challenges is just the health system challenges. So you talked about the challenges the patient faces. I think, Ken, you touched on this in terms of the sustainability question as well. So if you think about what option B plus means, it means that every woman, once she becomes pregnant, is going to be on lifelong ART. You know, we know that there's women that are entering reproductive age all the time. So what's happening is you're having the cohort of women who are requiring treatment to get bigger and bigger and bigger and bigger. And that, I think that sustainability question is on a lot of people's minds as well. So,
yeah,
for sure. All right, so we got some more questions. So I'm going to try to move us along a little bit. The next question is, what measures have been put, this is Mandy, what measures have been put in place to ensure that the research being conducted reaches those living in the remote areas of Malawi? Yeah.
Malawi is largely a rural area.
Yes.
So when we are designing our research programs, we already know we will reach those rural areas. I'm not saying we don't have urban centers. We do have urban centers, but the large part of it is a rural area.
Right.
So our research design, our methodologies, our plan to conduct research already factors in that we will go to the rural areas. In fact, when we are coming up with research questions during stakeholder meetings, frequently we do go to those rural areas to appreciate the sort of problems that the people are facing. And after the research has been conducted, we conduct some dissemination. These are the findings, these are the recommendations that we believe the government will help to implement.
Right.
So there is no danger that people or populations in the remote areas will not be reached through research.
Right.
They are always there, we will reach them.
Right.
But maybe one other thing that I can mention is that Dignitas International, in collaboration with the Ministry of Health, have established what is called a knowledge translation platform. This platform has got various issues that it is going to address. One of them, of course, is bringing together scientists and policy makers, so that whatever health policies that are going to be made should be from results or evidence generated through research. But the other section of knowledge translation platform is the general or the simple dissemination. So if we've conducted research in a certain rural area and we believe the findings are relevant to a wider community of similar type, then the knowledge translation platform will help to reach those populations which may be situated in those rural areas. Right. So research at Dignitas will reach those rural areas.
Yeah, so we've got it covered. And I think that we have it covered in the sense that that knowledge translation aspect, whether it's to policymakers or to the population, is integral in terms of how we approach research and how we approach our programs. So we talk about the different areas of work that we do. We do direct program implementation, health system strengthening, operations research, and knowledge translation and advocacy. So it's part of our vision and part of our mandate. Yeah, so that makes sense. All right, I'm conscious of the time and conscious of this growing list of questions. Okay, so the next question is from Natasha in Toronto. All right, so this one just came in. How were you able to break through the barrier of getting HIV-positive pregnant women to identify themselves and come to the clinic to be treated? So talking about access to HIV testing amongst pregnant women. Any comments?
Do you want to take that? Shall I try? Okay. That barrier is still there. But let me start by saying that barrier is not it's
not disappeared.
It hasn't disappeared.
Yeah.
It's still there. The current national strategy to try and overcome this is by a policy that is called provider-initiated HIV testing and counseling. So any person that accesses a health facility in Malawi at an early stage of that process will be entertained by a healthcare worker and stimulated to undergo an HIV test.
Right. And it's opt-out testing, right? So people are offered or the provider-initiated testing is about offering an HIV test, and the woman or anybody who presents has the option of accepting or not accepting the HIV test. So it's not forced.
Of course, it's not compulsory,
but
it's quite strongly recommended.
Yeah. Okay.
Still, that is still a barrier.
Yeah, and we're working on it in terms of our medical programming as well, right?
So the question, for instance, is in this pure study that I mentioned, can a mother, in case of women who are pregnant or breastfeeding, can a peer mother have an influence on such women as a mentor to overcome some of these concerns that the woman might have? We don't know whether that will be effective, but it's a possibility.
Okay, good stuff. All right, I'm going to move things along a little bit more quickly, so I apologize. But the next question is from Chuck in Toronto, and he asks, or he states, this is based on it, I think we tweeted this recently as well. So the question is, between 2009 and 2012, there was a 52% decline in new pediatric HIV infections in Malawi. And ART for eligible pregnant women increased from 13% to 86%. So his question is, what are the next steps in eliminating mother-to-child transmission? We've had some successes. Where do we go from here? Maybe you can start, and then you can kick in if he misses anything.
Yeah. Okay, thanks for that question. I think it's already partially addressed. If we look at the deficiencies that we currently see, is that women access care late. So often women come into care during pregnancy at a late stage. Quite a few women access antenatal care at the time of delivery.
Right.
Yeah. So that is something that needs to be improved.
Yeah.
Prevention of mother-to-child transmission will be far more effective if women start treatment after the first trimester.
Yeah.
So that is one of the areas where improvement is needed. And in general, as we discussed, there is still a concern in the percentage of coverage of HIV testing in this group. It has improved, but we hope that it can still further improve.
Right.
And then in a sort of a later stage, when women have started on ART, there are worries about the retention, as we discussed, and it's really important that we try and find ways to retain women on care as well as we can.
And I mean, that illustrates, I think, an important point. The research, because this goes back to the studies that they were describing, the PURE study and then the evaluation of B+. We're not coming up with these questions out of the blue because they're scientifically interesting. I mean, obviously they're scientifically interesting, but they're really relevant to the context that we're working in and deal with real challenges that we think we might have in the future, and we're trying to proactively understand the issues that might help or hinder the work that we're doing. Right? Yep. Okay, so a couple more questions. Oh goodness, okay, all right. So we've got 1, 2, 3, 4, 5 more questions to go through in 7 minutes. All right, we'll do our best. Okay, this looks like another question for you. You're being put on the spot tonight. All right, all the clinical questions. So this is another question from Natasha in Toronto. Are there any studies that might have confirmed or ongoing to see if there are any kind of interactions between the antiretroviral drugs and birth control pills for women who might be using this to prevent pregnancy? Excellent question.
That's a very good. That's a very good question.
Yeah.
So I think already for a somewhat longer time, we know that there are interactions between some of the antiretrovirals and some of the oral anticonceptives,
Right.
making those anticonceptives less effective.
Right.
And therefore, it's always been the advice that if people are on such drug combinations, that they use an additional means of birth control.
Right.
There are also concerns about the use of oral anticonceptives and other hormonal anticonseptives and the rate of progression of HIV disease. And there's currently a hot debate going on about that. The most used form of hormonal anticonceptive that we use in Malawi is a daypole injection of a progesterone drug. And as far as I know, there are no major concerns with the antiretroviral drugs that we use in our program.
Right. For those people out in Canada, that's the Depo-Provera. That's the trade name in Canada.
Right.
It's the same similar formulation.
Right.
Okay. All right. Next question. This is from Robbie in St. Thomas. Can you please elaborate on measures that are in place to maintain high levels of adherence to the Pmtct protocol, given that so much of the population lives in rural areas and transportation is such an issue? We've addressed this a little bit, but maybe you can summarize it, Ken, for us in 30 seconds.
Yeah, we did say, in as far as HIV program is concerned, there is a decentralized system. So this means that HIV treatment, HIV programs will be available even in the rural areas, so that women who need this service will not have to travel. They will be there. The services will be available in their communities, and we've also increased the number of healthcare workers who are trained in providing of this. This is actually one of the works that Dignitas is heavily involved in mentoring and in training community or health workers in all sectors of society, in all locations, rural and urban, to make sure that they are fully equipped, or at least reasonably equipped, not fully equipped, but reasonably equipped to deliver health care in relation to HIV and AIDS.
Yeah, for sure. Okay, we're getting there, almost there. Yi Min from Toronto is asking, how successful are expert mothers in assisting more mothers to enroll and stay on Option B Plus program and antiretroviral treatment?
That's a really excellent question. And the answer is, I don't know.
We're trying to figure it out.
And in fact, it's nice that she asked this, because it's exactly one of the questions that we want to investigate with that study that I mentioned, this cluster randomized trial, looking at the use of such mentor or expert mothers in two different models of care, one at health facility, one at community level, and what the effect this will have on uptake and retention. At the moment, we don't know.
Yeah, I think Yumin needs to be a researcher, because she's asking very good questions, isn't she?
Indeed.
All right, so I'm going to have two more questions, and I don't think we'll be able to take any more. These are logistical questions, so that's why we've saved them to the end, or administrative questions. So the second last question is this webinar downloadable? And as I mentioned earlier, we are recording this webinar, and we will make it available on our Ustream channel after the broadcast. I think we were probably online, hopefully, for most of this, so you've been able to appreciate what our panelists. But certainly, if you want to go back and listen to anything, then you guys are going to be up on the web very shortly in perpetuity, I'm sure. All right, the next question is, how can one become part of the Dignitas research team? Well, we do our research in Malawi, so we periodically do have research vacancies in our Malawi office. If there is any vacancy, then it would be posted on our website. So if you're interested, feel free to check out the website. And the website is www.dignitasinternational.org. Well, I think we're pretty much out of time. We have a minute left. To end, I just wanted to say on behalf of you, Ken, and myself, wanted to thank everybody for your viewership, and also just express how proud we all are for being here in Malawi, being a part of Dignitas and the work that Dignitas is doing. We feel like Malawi is at a very crucial stage in terms of health policy with introducing B+, and we're so fortunate to be able to contribute to the research and the evaluation around this very, very important initiative that other countries have started to think about adopting or have adopted. But I think we are in the process of rolling it out as in the public health system. So I think eyes are on us as well, and we feel a responsibility to evaluate this and to do it well, and to do it with integrity and do good science and good research. So the research is a big component, but I know for me, and I think I'm speaking for you and Ken, a big part of what keeps us going here in Malawi is the on-the-ground results that we're seeing already. We've been working on Option B+ for about a year now, and I feel anecdotally anyway in our experience, we are seeing an impact on people and communities that we're working with, that we're seeing in the clinic or that we're coming across in the rural villages or in the rural areas as well. And it's really heartening to see women accessing care, getting better care, HIV-positive women really having an opportunity to do something for their children and their families by starting on antiretroviral treatment. They improve their own health and really have the potential for raising HIV-free children. Before signing off, I'd also like to thank you, our supporters out there, for being a part of the Dignitas team as well. Without you, your support really is so crucial, and we simply couldn't do the work that we do. So we thank you for your past contributions, and if there's anybody that wants to make a contribution towards Dignitas's work, you can do that on our website, like I said before, www.dignitasinternational.org. In the meantime, we look forward to continuing the conversation. You can do that by liking us on Facebook and following us on Twitter. Is there anything else that you guys have to add?
No, thank you very much.
Yeah, all right. Well, thanks so much, and good night from Zomba.